There are a lot of patients who come to us for a secondary procedure, fat transfer, where they have been done by another surgeon, or they have had prior liposuction as a contouring procedure in the past. Unfortunately, a good number of them seem to have experienced some kinds of contour irregularities. I have to tell those patients that it's highly variable whether you can make an improvement in these contour irregularities. Surgeons have a different way of approaching their liposuction, and they find really what kind of works for them. But those areas of contour irregularities is where material has been thinned considerably and scar tissue may occur. And sometimes you can feather things out, and sometimes you can add back a little bit, and sometimes you can make improvements. But I honestly tell patients, look, I can't guarantee that we're going to be able to make things better. In addition to that, you have to be honest in that you can make something maybe even a little bit worse. You get into a situation where there's a significant degree of scarring. I don't know often what the process was. Even if I did, I find it highly variable from surgeon to surgeon. So it's not necessarily just that technique, but an individual predilection to certain degrees of scarring. So that's the situation when we see patients on a secondary basis. As far as patients that come to us for a primary procedure, as a sculptor, I like to think that we minimize. It's rare that we have them. They're usually minimal. A lot of times if there's anything required, it can be a little bit of local feathering. But I've basically designed and refined the technique that I use for liposuction over a good 25, 30-year period of time. And I take my time. I'm very meticulous about approaching this. We do a lot of patients who are quite thin. So we try to minimize that. I'm maintaining desirable characteristics of someone's figure. I'm refining where I can, and I'm hopefully avoiding the contour irregularities. But when they do occur on that rare occasion, as I said, it's relatively straightforward. If a patient is able to make a trip back to see us, under even a local anesthetic, we can often feather something out. But that's the key, I think, avoiding them from the first place. And when we go back and I do a secondary on a patient of mine that I've done the primary surgery on as well, because I know what's I've done, I also know the approach and the technique. I'm really thinking well ahead of that curve from the standpoint of trying to maintain not only the contour, but a cellular population that we can look to if we need to in a secondary or a salvage situation. And again, we can avoid a good bit of the pitfalls when it comes to contour irregularities. So it's real important, as I said before, that if I'm able to get to a patient in a primary, then secondaries are much less of a pitfall.